Can you guys hear me and see my screen?
Yeah, perfect.
Okay, good. Yeah, I'm gonna go through from physics point of view of HDR brachytherapy here for prostate cancer we done here in at Stanford. So here's the outline of my my talk. I'll go through about equipment needed for HDR and then the workflow from setup to treatment done at Stanford. So here shows the let me get my cursor. Yeah, so here is our vaults. We have anesthesia capability in the treatment vaults, and so for HDR definitely we need the afterloader. We have variant Bravos afterloader, and then we do ultrasound based implant and also planning. So we have a BK spectral ultrasound system. So here shows the stepper. So mount. So these and here shows the templates, the grids we have for prostate, and here shows the assembled transducer with the stepper. So for the steppers, will be mount to the stabilizer. The stabilizer will be fixed to the table. So something we're using cervical stabilizer. So this is essentially is kind of assembled stepper stabilizer to the couch, to the table. So here I think a cervical company, they provide a very nice YouTube video to tell people like how to assemble everything. So these are the majority of the equipment needed for prostate HDR. And here, before I move on to the step-by-step, here's a nice video from New York Times, actually for LDR, but the procedure is kind of similar. So after position, then doing like ultrasound imagings, and we've actually acquire images to the prostate, and then they do at some places they inject the jelly to the urethra, try to visualize the urethra more clearly. But at Stanford we don't. We typically should be able to see in the ultrasound, and then after that doing the needle implant. So here's a needle emplacement kind of thing. I will mention it later. So for the setup, we do general anesthesia at Stanford, and after anesthesia, the patient is set up in a dorsal lithotomy position, like here shows. So this picture is not from Stanford, but we have similar thing as more kind of similar as this side. Yeah. So after setup, so we will move on to the implants, essentially putting these needles to the patient. So this is the grid I showed before that we used for prostate, and this shows a typical needle placement during the implant. So, but each implant is tailored to different patients anatomy, and typically at Stanford we using 15 to 17 needles. Can cover most of prostate size, but we do up to 20 needles for like larger, like 80 or 85 cc patients. And a rule of thumb that for the needle placement, so these needles should be 7 to 10 millimeters apart when we put in needles. So this grid, the grid size is 5 millimeters in each direction. So and the needles from here we can see all the needles are nicely uniform distributed around the whole gland, but so all the needles should be within the prostate. And particularly for the urethra, we try to keep the needles 5 millimeters from the urethra. And also at Stanford, we purposely put a central D low this where the urethra is located along this this D-lobe, but we purposely put a D-lobe needle post to urethra to cover the base and apex. Because under the ultrasound guidance, we can clearly see the position of the urethra, so we try to avoid the needle go through the urethra. And also for the posterior needles, we try to keep around 5 millimeters within the prostate. You can see here from there. So here shows a typical needle placement using 17 needles. After implant of needles, then we take image acquisition. So here by the way, we're using the Vitas variant Vitas platform for our prostate brachytherapy. But if some places if you're using Lectzia after Lodo, then probably you're using CT-based planning. But in our side, we're using ultrasound-based planning. So after implant, we acquire 3 volume images. So transversely acquired the images with slice thickness of 1 millimeters. So we starting from like close to base and go inside about 2 to 3 centimeters and go back past to the apex of apex and about like 2 to 3 centimeters past the apex. So here's kind of animation of the image acquisition. So here shows the 3D views of the ultrasound image we acquired with needle implants. So after image acquisition, then for I will see for majority of the case we have MR images. Then and also we have in-house auto contouring software. It actually provide us the contour of prostate and the lesion. So typically we will fuse the MR to the ultrasound. So particularly for the lesion area, so we try to kind of make it hotter in the lesion area. And after that, physician will contour the prostate, the urethral, rectum, bladder, and bladder neck. So here shows kind of contourings of this prostate and organ of risk. So after we get the contour, then so physicists will do the planning part. So for the planning parts, first have to digitization of the needles. So essentially, direct from the ultrasound, we can we put the needle locations. Actually, lets the treatment planning system know where the needle is actually, and so we essentially start from the posterior needle and then go up top to the top anterior needles, just one by one. And then here, because for ultrasound images, in this case, you kind of nicely see the tip of the ultrasound of the needles, but in some parts of the particularly these anterior needles, because of the artifact created by these posterior needles, so you may not able to visualize the needle tip very clearly. So as a kind of second verification, we have a measurement once the needle put in. So we measure the needle outside of the template, and then we know the whole length of the needle. So we exactly know where, like how deep the needle within the patient. So we're using this data to verify our digitization. And we've tried to make this this accuracy to be within plus minus 1 millimeters. And after the digitization, so we get the images, we get volumes, and also we get the needle locations. So then at Stanford, we try to create what we call the tuning structures for initial optimization by the software. So we create this structure is by expanding from the prostates in each direction by 4 millimeters. And here's a template we use to get our initial plan. So essentially, we set different priority to prostates, OERs, and also the tuning structures. So running kind of one run of this kind of inverse optimization process, we get our initial plan. But for pretty much every case, we have to fine-tune manually. So for fine-tune, there's 2 ways to do it. First is you essentially will directly drag this isodose line, and then it will give you the dual times for each positions. And also the other way, you can directly manipulate this dual times using this dual control window. But for prostate, you essentially, like, you have 15, 17 needles. It's kind of difficult to directly using this dual control settings. So typically we start with the dragging the isodose line, and then if we really need some specific area, for example, the tumor area, we need this dual to be more time or reduce the time will cover some places, or then we can change using the dual position. So for the symmetric constraints, so for prostates, I think we're using following ABS guidelines. So as Hilary mentioned, we have 2 regimens. One is monotherapy, 27 curies in 2 fractions. So for this case, for majority of the OERs, we have same, but for the monotherapy, we try to keep the V125 to be for uracil to be not 0. Essentially, the isodose line of 125 not overlays with any part of the uracil. And for the boost, we try to keep the 120, but majority less than 0.1 cc. But majority of the time, we actually keep this 120 to be 0. So here shows kind of typical examples of our planning. You can see that the conformity, and also this, I don't know, it's kind of small, but this purple area is the lesion from the MR we fuse to the ultrasound. So typically we want 125 isodose line to be covered nicely to the tumor area. And so after the planning, so we go to the final treatment delivery part. So essentially you connect the afterloader. But by the way, this is the photo is not taken from Stanford, but I borrowed from this chapter and textbook. So essentially you have afterloader, you connect the needles with transfer tube, and then and every people coming out. So you have vision monitors used for anesthesia to look at the vitals of the patients outside of the vaults, and everyone come out, and then we deliver the plan. So that's probably it, and thank you for your attention. And the last part, I think, you know, from physicist point of view, this is a list, just list kind of APM task group reports all related to the prostate HDR. Particularly, there's a very recent one is talking about MR for HDR brachytherapy, including the gynecology and the prostate part. So, yeah, thank you.
Thank you. Thank you so much, Shyan-Цзin. Excellent, excellent lectures. I would like to open the floor for questions. While people are getting their cameras turned on, I would like to ask one question to you, Hilary. So obviously, to me, it seems that HDR prostate is very dependent on the physician inserting the needles. I feel the quality of the implant can be really drastic from the first time user to experienced physician. I'm just curious, how long did it take you to become good at it?
I don't know. I wish we had like better data to find that. But I would say maybe like doing it a year independently. We were pretty like high volume, so we do total like up to 6 cases a week, not always, but I've been doing at least 2 cases a week routinely for a while. So I'd say maybe like a year in, I felt a lot more comfortable. It makes it much faster. I would say I was pretty slow at the beginning, and I did a lot of things to try to like double checks and things that I don't do anymore that like made me more confident in like my contouring and things like that. I'd say that's the hardest part, I think, is the contouring post implantation of the needles, and once you get comfortable with that, it's a lot faster. But
yeah, thank you. Okay, so I see people turned on the cameras. You would like to ask questions?
Yes. Hello, I'm the Shepel radiation oncologist from Kyiv, but now I was inside the Stanford radiation department. Thank you for this opportunity. Very interesting lectures about the prostate cancer. I have some questions. First question is about the prostate cancer low risk. Have you the time when you observe the patient and do and don't do radiation therapy? No matter HDR or low HDR brachytherapy, what time you observe these patients, and what reason when you start radiation therapy?
so yeah, for low risk, I'd say most of us, the surgeons and the radiation oncologists, will recommend active surveillance for those patients. So like every 6 months PSAs, and then the surgeons usually follow them, but they do like interval MR imaging and biopsies and whatnot. And only would we treat them if they, now fell into intermediate risk, or sometimes patient preference. We do treat low risk patients, but it's mostly like because they're pushing and they want to do it but usually we'll recommend active surveillance.
Thank you. And second question is about the technique of radiation for treatment. You have some other direct for do the brachytherapy. If on first step you do virtual plan, and after that you insert the needles.
She means pre-plan, probably.
Yeah, pre-plan. Then you had virtual plan, pre-plan, and after that you insert needles according this pre-plan.
Yeah, we don't, for HDR, we don't do a pre-plan like LDR. LDR, of course, you need a pre-plan, but our practices, we don't do a pre-plan at all, actually. We don't even do like a volume study before. We just try to select well based on gland size and clinical factors like going into it, to just try to well select patients.
Do you have a template that you typically use for average size? Yeah.
Oh, size. I mean, 30 to 60 is pretty, like you're probably going to be fine unless the patient for some reason has got a super narrow pelvis. So usually if they get up to like 80 plus on the MR or ultrasound, I'll say I won't do it. I've gotten burned before. It's not a good experience.
Definitely. Anesthesia. Okay.
Thank you very much for answers. Thank you.
Dr. Sokolowska, you want to ask a question?
Good evening. I'm Dr. Sokolowska from Ukraine, from the Kyiv. And actually, thank you for the very interesting lecture that expanded our mind, because it's very precisely and very intelligent treatment as for me. And my first question, what about the possible urgent situation during the procedure? Is it happens bleeding or perforation?
You're saying like anything acute during the procedure that's makes them very sick, kind of a thing?
Bleeding, perforation.
No, we don't really come across that. I mean, if you stop any blood thinners or supplements they're on that could thin their blood, and then really, even if you go into the bladder with the needle or something, it's hard to even know if you've done it. But on ultrasound, if you think it's too deep, generally if you just pull back and then irrigate their bladder once the case is finished, that seems to be sufficient. I don't think we've ever had a major issue with that. Some places do involve urology. We do not. But some places they'll do like a end of the case cystoscopy or something like that to just look in the bladder. We don't do that. But knock on wood, we really haven't had any major complications with that part of the procedure. And I'd say the main thing is just that they could get obstructed because we take the catheter out, we make them void. And if they don't void, we put a catheter in before they leave. So we kind of manage their urinary function closely. Theoretically, there's a risk of like a rectal tear, injury, perforation. I haven't heard of that in this procedure, but I have heard of it in other, like a urologic ablative procedure where they use like a transrectal ultrasound probe and a prostate ablative treatment. But yeah, so it's really well tolerated. They do very well, I would say.
Very confident afterwards. And is it possible to have an overlaps in the needle placement or not?
Like have them like close together?
Mm-hmm.
Yeah, I'd say maybe Cash could answer that, but if we try to, our physicists are there the whole time and we really try to ensure that they're adequately spaced. But I think if they tend close together or they end up close together, they'll often just like turn it off in that location and not use it, for example, to minimize the dose. But Cash could speak to that better, probably.
So you control on the procedure, its placement.
Yeah, I think typically we can control during the implant. We try to kind of nicely avoid that happen. But in case if it's end up with too close, so and we probably just using one needle during the planning. So.
Thank you. And what is the average procedure time and time for anesthesia for the patient?
It's probably about 3 hours. I'd say 3 to 4 hours. You know, that's kind of start to finish. So like by the time they're asleep to like the time they wake up. So the anesthesia time might be like a little bit shorter than that. We do general anesthesia. Other places I know here do like a epidural and conscious sedation, things like that. So there's other ways to do it if you're not able to do general.
Okay, and what is a treatment schedule when we need more than 2 fractions, 2 or more?
That's a good question. I actually haven't ever done that, so I don't know how people do it. I know some places admit the patients and keep them, you know, overnight and treat them like BID, similar to like a GYN
Yeah, we
interstitial.
used to do that at Mayo,
Yeah.
2 a day.
Yeah.
But then we saw that the needles actually move. You implant them, but needles move for the second fraction. So it's actually better what you do here at Stanford, just 2 fractions, 2 inserts.
And it takes out the variability of like moving them and getting
Right.
a CT and
Right.
yeah.
The last one question, it's a bit tricky. Can we compare the two methods of the prostate cancer for the early stages, radiosurgery and brachytherapy? Is they equal, and maybe pros and cons of them?
I think so. That was one of the questions in the chat about SBRT. So I think that's right, your question as well, like SBRT versus HDR. Yeah, I think, I don't know of any direct comparison data, but I mean, all of the retrospective data on SBRT, especially for low and intermediate risk, is excellent. So I'd say we also clinically, the patients that are candidates for HDR are also good candidates for SBRT. And I often offer both of them. And, you know, the patients often have a strong preference just based on the procedure and things like that, like which one they want to do. And I think generally speaking, either one, I don't have like a very strong preference. But yeah.
And Hillary, so if you were to start the HDR procedure for prostate in your clinic, what's needed to get it started from your standpoint? And the same goes to Shyan-Цzin. So from your point of view.
I mean, a really good physics team who's going to do it with you. Because, well, I mean, again, we do all of our cases with physics, which is like a huge help and gives a lot of confidence for me as the clinician. So that's one thing. I would say also you really need to think about how you're going to do this with like sedation resources. Like, can you involve the anesthesiologist? Can you not? That's really, really important and an easy, nice way to do it. But if you are not able to have them like transferred to the outpatient surgery center or have a recovery unit, you have to think about like your nursing, who's going to recover the patients, because it can take, you know, a long time, obviously. Yeah, those would be kind of the main logistical things I would think about first. Before deciding like how you're going to do it, what's the fractionation, what kind of planning you're going to use, ultrasound-based planning or CT-based planning. That would be another big decision point, I think.
Thank you. And Shyan-Цzin, from your point of view?
Yeah, I think I from my point of view, that brachytherapy is kind of very specialized teamwork. Definitely you need team effort on that. And for example, here we like during the needle implants, particularly for prostate, if you know physicians cannot get there, it will be a hard time to you know planning. But here at Stanford, we have Mark and Hillary kind of very every time they can get the needles exactly what we want. You know, that will make planning part very, very straightforward. And also, I think we have nice therapists here to help with, you know, warm up during the procedure and everything, making smoothly. I think that's kind of team effort. That's from my part. And also equipment. Definitely, that's another. We get Virgin Bravos. It's kind of compared to the old Gamma Met. It's kind of we gain a lot coverage in the base side. So that's another thing I will mention.
Thank you. Any more questions? Excellent.
I tried to answer a few in the chat, so hopefully that's helpful.
Yeah, thank you. Thank you. Great lecture. Thank you so much. So next lecture will be on Wednesday, for TBI, total body radiation. It's going to be me and Susie Hineker talking about total body radiation. So see you there then. Thank you so much, Hillary and Shenjin.
Thank you.
Bye-bye.
Thanks. Bye.